Hello, everyone. I'm Rose Gerber, COA's Director of Patient Advocacy and Education. Thank you for joining us today. As always, I have a few updates before I introduce our guest. 1 week ago, we were on Capitol Hill meeting with our legislators on various issues related to cancer care. Our group included COA staff, COA members, and most importantly, cancer patients, survivors, and caregivers, all CPAN advocates from across the United States. I want to give an extra special thank you to all of the CPAN advocates that were with us on the Hill that day. These advocates shared their patient and caregiver stories during our multitude of meetings on Capitol Hill. And by sharing their experiences, they brought to life the personal impact of cancer care policies and the anguish that a lot of these policies can sometimes have on patients and caregivers. I heard many positive things about Hill Day, and something that was especially touching was knowing that when these cancer patients and caregivers opened up during these meetings, they moved people to tears. And that is very powerful, to allow yourself to be vulnerable when trying to share your experience and hoping to make a change in healthcare policy. During our meetings, one of our messages was keeping middlemen, pharmacy benefit managers, PBMs, out of our healthcare. And our message was very simple. PBMs delay, deny, and disrupt critically needed cancer care. These delays cause additional anxiety for patients and their caregivers, and we need their help to stop these abuses. Our guest today is Dr. Debra Patt, or I should say the amazing Dr. Debra Patt, a practicing medical oncologist and executive vice president at Texas Oncology. Dr. Patt is a healthcare policy expert and has provided her insight and knowledge on PBMs in front of the United States Senate. Today, Dr. Patt will be helping us understand how PBMs negatively affect patient care, how PBMs stand in the way of lowering our healthcare costs, and what advocates can do to stop PBM abuses. Thank you and welcome, Dr. Patt.
Thank you. Thanks so much for having me, Rose. And thank you all as patients for being part of COA's Patient Advocacy Network. I'll tell you, I spent a lot of time at the US Capitol and at the state capitol here in Texas advocating for my patients. And I think as a doctor, we're very effective advocates, but there's no one that's a more effective advocate than patients. And I'll just say as we get started, I'm grateful to Rose for setting up these educational webinars so you guys can learn about some issues that influence the ability for you to have access to cancer care. But remember, nobody expects for you to be a health policy expert. All you need to do is tell your story, because that is really important and effective. So I will say, as I talk about pharmacy benefit managers and as we talk about other issues that pertain to the ability to access cancer care, things like network adequacy and white bagging and cost of care by site of service, they can be really complicated. And I just want to tell you that you're not actually expected to know all of those things. Remember that your voice is incredibly powerful as a constituent because you're a cancer patient or because you're a caregiver helping with a cancer patient, and that makes your voice really powerful. And all you have to do is tell your story. COA has a lot of policy experts that can help put that in the context of pending legislation, challenges that we're facing in cancer care delivery. So remember that your role here is really just to tell your story. So I'm going to talk to you about some of the details of cancer policy because it may be enlightening for you to understand how they fit into your care delivery. But just know that don't worry about getting caught up in the details, because you don't have to know that, and it doesn't diminish your effectiveness in any way as an advocate merely to talk about the challenges that you've had, because there are folks within COA that can help put that into context. So if you go to the first slide that I have, really I'm talking to you today about pharmacy benefit managers. And pharmacy benefit managers are third-party administrators that are contracted by health plans and large employers or government entities to manage prescription drug benefits. They were created in the 1960s, and today they have really increased their scope to manage things like networks, determine drug formularies, to set copays, to set criteria for prior authorizations, and to select the pharmacy for patients. So I will say historically that they've kind of masqueraded as a cost saver. In fact, I'll tell you, in Senate testimony, when I was testifying before the Senate and talking about some of the roles of PBMs and transparency, there was another person that was testifying that was likening them to the Costco's of pharmacy, that they really were cost savers. But in reality, it's a cost multiplier. And I'm going to talk you through why that's the case, because they're not acting like Costco to you in terms of purchasing drugs. And they really benefit from every node in the drug supply chain with rebates and spread pricing, which for them is completely legal. So that's just sort of a background. Now I'm going to give you a little bit more of the details about how pharmacy benefit managers act within the system so you can understand how they act, and then how they are really part of insurance companies because of the vertical integration that we see today. And that's true in a lot of healthcare dynamics. And that's going to help you understand why it can be sometimes in their advantage to do things that aren't in the best interest of cancer patients, and how, when we advocate, we can try to make sure that your interests are really protected, and that we tell that story. If you go to the next slide, this is an example of the healthcare marketplace and really understanding where pharmacy benefit managers play a role. So you're all familiar with, up here at the top center, we have the manufacturers. So they make the drugs that you use. The manufacturer will usually have a services agreement through a wholesaler to then distribute medications that you take to a pharmacy. But there's an agreement between the manufacturer and the pharmacy benefit manager that benefits the insurance company, that's the third-party payer, around the medications that you receive. So if you have, for example, 3 drugs in a class to treat your cancer A, and you're choosing between those 3 drugs, a pharmacy benefit manager might work with an insurance company to restrict the formulary to only give you access to one of those drugs. And they might make that choice because it's the most advantaged rebate that they have when the 3 drugs in that class to treat your cancer A may not be equal, right? So when you have 3 drugs in a class, a doctor might make a choice about which one to give you based on therapeutic efficacy, how effective it's going to be for you, or toxicity. Is there a drug here that's going to be less toxic for you? And that's not the same answer for every patient. So I'll just give you an example. If I write for a CDK4/6 inhibitor in patients with metastatic breast cancer, those are drugs like Kisqali and Verzenio and Ibrance, or abemaciclib, ribociclib, and palbociclib. Those drugs are in the same class. There's not comparative data, right, for efficacy on a head-to-head trial, but we do have toxicity differences. And if I had a patient with Crohn's disease or some sort of chronic diarrhea, probably not going to give them abemaciclib or Verzenio, because that's a known toxicity that's more with that particular drug. And so I want to have that choice. But if that's the only choice I have on the formulary, I may not be able to effectively treat my patients. So this is just an example of where sometimes a pharmacy benefit manager can be working with your insurance company or third-party payer in benefit design and in formulary restriction that can make you not have every opportunity to have a successful cancer journey. So that's a real limitation. And that might be because there are financial incentives that are aligned. So why are those financial incentives aligned in that way? I think is a really important question. And what I'll show you here, and this is from Drug Channels, if you can go to the next slide, is that there's a lot of what we call vertical integration. And what this means is just that within each insurance company, that they've really bought relationships with pharmacy benefit managers, specialty pharmacies, and sometimes even provider services. And so they're all under the same tent or the same company. And this allows them to be much more effective in aligning financial incentives for a particular outcome, right? So you can see here, the top line is examples of insurance companies like Blue Cross Blue Shield, Centene, Cigna, CVS Health, Elevance, Humana, United Health Group. You can see their respective insurance companies, pharmacy benefit managers, the specialty pharmacies that they're aligned with, and provider services. So if the PBM and insurance company are working to restrict a formulary, again, to give you access to a more limited number of a therapeutic class because of financial reasons, then there's an incentive for them to be aligned in that way, which can be challenging. Similarly, even by having this outside of your doctor's office, right? By having the pharmacy benefit manager direct your fill to a specialty pharmacy, frequently your doctor doesn't know when your prescription is filled. If it gets filled, there could be a 2-week delay, there could be a 30-day delay, there could be a multiple month delay. We frequently don't have insight into prior authorization when it's filled at an outside pharmacy. Now, if the script is filled at our medically integrated dispensing pharmacy because it's in our centers, we have line sight into that. We have knowledge of that because we can see that. But frequently it's not done otherwise. And so, for example, when I see a patient with metastatic breast cancer and I place them on a therapy of an endocrine blockade and a CDK4/6 inhibitor, and I write for them to follow up in 2 weeks so I can check their labs, frequently when I see them in 2 weeks, if their script has been steered to a vertically integrated specialty pharmacy within the PBM's vertical integration, when I see them back, they've not even started their medicine. They've not gotten their medicine. They're unaware if they've been authorized to receive their medication. And so, so there can be a lot of delays and deters in care. And as a doctor, as the person sort of managing toxicity, I don't have insight into that. So I can anticipate how to follow my patients to make sure that they have the best possible cancer journey possible. So the vertical integration piece is what creates some of these financial incentives for things like spread pricing within pharmacy benefit managers. So how does this affect you as a cancer patient? If you can go to the next slide. So how does this affect you in your cancer journey? So because of spread pricing and rebates driving decisions on formulary restrictions, it can cause you to have limited options, and also it can cause costs to increase. So how does this happen? Rose kind of brought us up this example at the very beginning, but if you have, let's say you have a PBM and an insurance company that are getting a substantial rebate from a higher cost drug, that there might be an incentive to put that higher cost drug on formulary, whereas a lower cost drug that's in the same therapeutic class that may be appropriate for you as a cancer patient is not on the formulary because there's not a financial incentive to the PBM and insurance company, and you may not have access to that lower cost drug. By doing that, not only does it increase your cost of care, but if you have an employer that's funding your cost, it increases their cost of care. And because the total cost of care is increased because you have a more expensive therapeutic choice, it increases things like your premiums to your insurance company for you and your employer. So it increased the total cost of care for your cancer journey and also limits your therapeutic options. Secondly, because pharmacy benefit managers are not integrated with the clinic, with your doctor, prescribing can often be incorrect and delayed, driving costs and delaying care. So in the example, again, that I gave, I'm a breast cancer specialist, and so all my examples are really breast cancer. When I give a CDK4/6 inhibitor with an endocrine therapy for patients with advanced breast cancer, frequently I have to dose reduce patients because of toxicity. So maybe I start at the regular dose, but then when I see them in 2 weeks or 4 weeks, I'm decreasing their dose. And that's easy for me to do when the script is filled in my clinic, because I see them, I check their labs, and I write for their script, and they can walk over to my pharmacy and get it. But when it's filled at an outside PBM that is vertically integrated with their specialty pharmacy, they've already sent them the script for the next month at the higher dose when I've made a dose adjustment, and they can no longer take that medication. And once it's been sent to the patient, there's no way that we can take it back. It's not like it can be refunded. In that example, those medications cost more than $10,000 per month. And so that is a hugely expensive waste that is introduced into the system. And then frequently they won't let them get the lower dose until the next month, which then delays my patient getting appropriate therapy. And so that's a challenge because care coordination is not optimized between your doctor, the PBM, and the specialty pharmacy. There's really no communication between the PBM, the specialty pharmacy, and your doctor. And so that creates a lot of waste in the system and then also doesn't allow patients to get appropriate and timely care. The third example that I wanted to talk about is because of formulary restrictions, sometimes patients can't even get the drug that they need. So in my example of maybe there's 3 drugs in a class and your formulary says you get only have access to the first drug for your cancer A, let's say I wanted to give you drug 2 or drug 3, I may not be able to do that because of the restricted formulary. And then lastly, I'll just say that because they're not integrated with your clinic, your doctor doesn't have insight into the timing of you getting your medication. So patients come and they're very confused and frustrated. And I'm very confused and frustrated because I can't tell them, this is the day that you're going to get your drug. This is the day that you had authorization of your drug, because I don't have line sight into that because it's out of my control. And there's not communication there. So, so I think a lot of limitations in how it impacts patients. If you can go to the next slide.
Dr. Patt, if I may, when you were going over this slide, it reminds me of a phrase I believe I've heard you use and some of the other co-physicians is it's mind-boggling that individuals who did not go to medical school, do not treat cancer patients, are making these kind of decisions, interfering between your relationship and the patients. I mean, it is so hard for me to wrap my head around that because I know from experience that what comforts a patient is knowing that their oncologist is taking care of them, and yet you have all this interference. It's just astounding.
I think of them, Rose, like as if I'm trying to run a race and someone's put hurdles in the way, right? And so, and what happens, I think, when patients have to come off their therapy for a month because they've gotten the wrong dose of the medication from the pharmacy benefit manager, I think of those as hurdles that we're tripping over, right? And we want your journey. I often say to patients, we want their cancer care to be like a speed bump, not a train wreck, right? We want you to be able to run the race. We want you to be, you know, it's a marathon. We want you to be able to run it. So we need to try to manage those hurdles as we can. And when you trip over them and fall, it threatens your ability to complete the race at all, you know? And so, you know, we feel that, and I know cancer patients feel that. And so, you know, we want to make sure you're aware of all these potential barriers. And when you encounter them, advocating for a journey that's barrier-free is a much better course of action. If you can go to the next slide. So really, I want to, you know, if you hear nothing else from me today, that know that we really appreciate you all as a force in advocating for cancer care. You all as cancer patients are really effective advocates. Your stories are so powerful, whether you're patients yourselves or caregivers, it's incredibly powerful. Taking the time to come to your state capitals and the US Capitol to talk to our elected officials is critical, because healthcare is complicated. As I showed the infographic of pharmacy benefit managers and vertical integration, remember that our elected officials, by and large, are business people and lawyers that have chosen to go into public service, but by and large, really have no experience with healthcare except for how they and their family members have experienced it. And so in general, they're not healthcare experts. So you need to tell them as constituents how various policies impact your cancer journey just by telling them about your cancer journey. And that is going to allow them to have insight into the natural consequences of the policies that are passed or being considered. So really just tell your story and tell the story of challenges that you have. It is the most powerful tool. I think you guys are the most powerful advocates that we have for cancer care merely by telling your story. But again, don't feel like you have to understand all of the policy details, pending legislation, and nuance of that policy. I know when I first started being an advocate, I was a little overwhelmed by that. And I felt like I needed to know all of that nuance in order to be effective. And that's just not true. You guys are most effective and relatable just when you talk about how the journey has affected you. So I would just encourage you to participate in the process and be part of that, because it can be incredibly powerful. So I know we just have a few minutes left, and I want to be sure to answer any questions. I don't know if there's any that have come in the chat.
You can feel free to put any in the chat if you want. And while we're waiting to see if we get any questions, Dr. Patt, I have a question.
Yeah.
In your opening slides, you had a bullet point, and correct me if I'm wrong, that PBMs have been in existence since the 1960s. Is that correct?
Yeah.
So why now is there so much attention? Like, I know there's several bills currently around PBMs. So what's the explosion? Is it that we have more knowledge? Is it that physicians are speaking up more? Help us understand that, because 1960s to the current time, that's a huge span of time.
So I think initially pharmacy benefit managers were sort of, a really valuable service and working sort of like a Costco. I think that was sort of how they originated. But I think what's happened over time with the vertical integration is it's created financial incentives for revenue for insurance companies at every node of that supply chain. So, if it is from the manufacturer to the insurance company, there is a rebate, right? That's present for certain drugs, and that's a rebate that's negotiated between the manufacturer and the insurance company. When the pharmacy benefit manager is contracting with like a medically integrated dispensing pharmacy at your doctor's office or a specialty pharmacy, there can be clawbacks that are about more than 10% of total costs. They call them DIR fees, direct and indirect remuneration fees. There's steerage. Frequently, the pharmacy benefit manager is able to do some adjudication of the scripts or reconciliation of the scripts after they've been filled to see if there's any possible affiliation and ability to take other discounts, that they can split that additional revenue or profit with the insurance company to make it more remunerative. So this vertical integration that we see has really set the stage for a lot of profit sharing in between each node of that supply chain. And as a patient, you don't see that. You actually are not privy to it at all. And as a doctor, we don't see that. I only see parts of it because sometimes patients bring in their EOB or their bill explanation. And it's, you can see sort of what's happened with that. But as a patient, you feel it because you're being told, no, you can't have that cancer therapy. No, you can't have that cancer therapy in time. No, you can't have that cancer therapy without. I had one insurance company and PBM that would make us every 3 months go through a renewal, but it had to wait 30 days. So the patient could get therapy for 3 months and then off a month, and then therapy for 3 months and then off a month. So, as a patient, you just see the hurdles put in your way of your sprint or your marathon of your cancer journey. And sometimes you're going to trip over them, and sometimes it's going to take you out of the race. So I think as a cancer care provider, what we've appreciated is that sometimes patients can have very adverse outcomes, because I think that insurance companies and pharmacy benefit managers have approached this like they've approached many other diseases. But the truth is like, if you don't adequately control your gastroesophageal reflux, and you have to go to a different medication, it's probably fine, right? You have a little reflux, you don't sleep well a couple nights. But when you don't control your cancer, if you're treating it the same way, it's going to grow and it's going to mutate. That is the nature of cancer, and people are going to be at increased risk of death.
Thank you so much, Dr. Patt. We have one quick question. How can patients, and I think you've addressed some of this, how can patients be most effective in getting our message out by going to the Hill, going to state leaders, writing letters, et cetera? What do you feel is the most likely to make a difference?
I feel like meeting with our elected officials is the most helpful, to talk to them about your cancer journey. You know, cancer impacts so many, and so this is such a relatable story when people have challenges in their cancer care. And so that could happen in your local district. It might happen, you know, at your grocery store, at a cancer center opening, at a cancer center site visit. It might happen at your state house. It might happen at going to lobby in DC. You know, there are many places where one can be an effective advocate, and we can create those venues for you. It doesn't have to even be, you know, traveling is nice and coming to DC for a Hill Day is amazing, but it doesn't have to be that. You know, it can be, you know, on Zoom calls, it can be in your district. There are so many ways that you can be an effective advocate, and thank you for your advocacy.
Thank you so much, Dr. Patt, for your time today and for sharing your knowledge with us. Next slide, please. Thank you, Dr. Patt. And we have our next advocacy chat on Wednesday, June 12th. And next month is Cancer Survivors Month. And as Dr. Patt has consistently mentioned, we love hearing your stories. And one of the ways that we can hear your stories is by having you share your story on our CPAN website. So please visit it. A lot of times we look at those stories when we're looking for a patient to represent us in different maybe conferences or even coming up to the Hill. So thank you for spending your time with us today. And thank you again, Dr. Patt. Enjoy the rest of your day.
Thank you.
Thank you.